All right, hello to everyone. Welcome to the Auditory Learner. This is going to be a Perio 2 midterm review. And first time on this janky laptop of mine. Let's see how this works. All right, so the way this is going to go is we're going to talk about all her lectures and the information I have synthesized to simplify it. And we're going to go from the first week, which is Perio 2, reviewing the basics, back to clinical attachment loss. And we're going to go over the perio staging and grading, then the periodontal treatment, then into gingival curettage, the healing and repair, supportive therapy, and antibiotics and microbials. This should be very similar to what we did with the Perio 1 with Professor Cermenio. All right, so getting right into it. Okay, so let's start with week 1, the basics lecture. Let's understand that the coal is the area of tissue between teeth that is anatomically predisposed to growth of oral biofilm. It sits right under the contact area. The correct way to place your probe is 20 degrees angle interproximally. This is an oblique position that reaches the depth of the pocket or the crater, as it was stated in the um, lecture. Wrong angulations, calculus, and overhang restorations can be the cause of incorrect measurements. Make sure to understand that you're walking the probe around, and then the deepest reading per surface is going to be your reading. And out of those 6 surfaces, remember it's distal facial, facial, mesiofacial, mesiolingual, lingual, distal lingual. Those are the 6 surfaces there. All right, that's probing and the basics. The next thing is going to be week 2. This is important. We're talking about clinical attachment loss, CAL. All right, so we know that CAL is the distance from the CEJ to the base of the pocket. It basically is recession plus pocket depth. Okay, recession plus pocket depth. And what that means is when the recession goes apically, right? If it goes above the CEJ, we're subtracting. So that's very important, especially when it comes to pseudo pockets. So if we have a probing depth of 4 millimeters with 1 millimeter of recession, then the cal is going to be 5 millimeters. This is an example of adding. Recession is visible and not an inflamed pseudopocket, in which case you may have to subtract if we are doing pseudopockets. Again, attachment loss over time is the actual progression of periodontitis, not pocket readings. Okay, also remember that RAL means relative attachment level, and that is from the CEJ to the junctional epithelium. All right, and moving along. So relative attachment level is taking the measurements multiple times at different points in time to see what the CEJ to junctional epithelium was, but we didn't talk much about that. Now let's get into mucogingival involvement, okay, and mucogingival junction. So mucogingival involvement means no attached gingiva and the probe goes beyond the mucogingival junction. Okay, this means that it's measured by gently rolling and pressing upward with a probe or cotton swab from the mucosa to find a band of attached gingiva. Then we use a probe to measure from the free gingiva to the mucogingival junction. All right. So that being said, let's talk about inadequate attached gingiva. That is the limited zone of attached or keratinized gingiva, defined as less than 1 millimeter of keratinized attached gingiva. There is low blood flow supply there and can easily increase to mucogingival involvement. And so what we got to bring from this is, let's kind of review again one more time. So for example, let's say we have two teeth, 8 and 9. Number 8, we have inflammation going on there, and the inflamed gingival margin hides the CEJ. So here you have um, a pocket depth of 4 millimeters, right? But the gingival margin is like beyond the CEJ, which is like 2 to 3 millers beyond. All right. So, and that point, you're going to subtract. Okay. So it's the pocket depth plus whatever that measurement is from the pregingival margin to the CEJ. All right. Hopefully that's clear. Okay. Yeah. Okay. So now let's get into staging and grading. And for this, we're going to review what I said um, in the first lecture, in the first class of Period 1, but let's go over it real quick here. Stage 1 is 1 to 2 millimeters interdental cal, less than 15% bone loss. There's no tooth loss at stage 1, and the maximum probing depth is 4 millimeters or less. And it's mostly horizontal bone loss. Stage 2 is 3 to 4 millimeters interdental cal. Coronal radiographic bone loss is 15 to 30%. Okay, 15 to 30%. And the maximum probing depth is 5 millimeters or less. Also horizontal bone loss. Once we get to stage 3, though, is you have greater than 5 millimeters interdental cal. The radiographic bone loss extends to the middle third of the root, and you're also losing 4 teeth or less. In addition, you have probing depth that are 6 millimeters or greater, and you have vertical bone loss of greater than 3 millimeters, and you have truncations of class 2 or 3. Stage 4 is interdental cal, just like stage 3, greater than 5 millimeters, also extends to the middle third of the root, but this time you're missing 5 teeth or more. Not like stage 2 where you're missing 4 teeth or less. Stage 4 is 5 teeth or more, and you have like less than 20 remaining teeth, and most teeth are mobile of 2 or greater. So that's not good. And then the grading, we know A, B, C. A is slow, B is moderate, which is where most people are, and then C is very fast. So that's good. And then let's talk about the week 3 lecture, which is the periodontal treatment rationale. So the primary goal for periodontal treatment rationale is the elimination of periodontal inflammation and removal of causal factors such as tartar, plaque, and overhangs on restorations. Also to improve the clinical status, which results in reduced bone loss, elimination of pain, gaining of attachment, improved tissue contours, and maintaining oral health. We got to make sure we know these treatment planning phases. There's phase 1, 2, and 3, and 4. The dental hygienist is only involved in phase 1 and in phase 4. So phase 1, which is where the dental hygienist is involved, is non-surgical phase. This is the elimination of etiological factors by scaling and root planing and leaving a smooth surface. It also involves plaque control, patient education, microbial therapy, reevaluation, and maintenance therapy. That's phase 1. Phase 2 is surgical, not us. Phase 3 is restorative, not us. Phase 4, back to dental hygiene. This is periodic recare visits tailored to the patient's needs. Also, this involves reviewing oral hygiene, health status, and includes behavior modification for oral hygiene instructions and indices such as marginal bleeding index and bleeding on probing. Okay, so we also need to understand the prognosis. There's an old way and a new way. For prognosis, the most important factor for tooth loss is the periodontal pocket when it comes to prognosis. So the periodontal pocket, the furcation, the crown to root ratio, and the fixed abutment status and bone loss percentage. Posterior teeth are always more likely to be lost earlier than anterior teeth due to greater complexities. and convexities. So now let's talk about the old way and the new way of prognosis. So the old way of prognosis is we have good, fair, poor, questionable, hopeless. Good, fair, poor, questionable, hopeless. That's 5. There has to be 1 or more for each of these. So for good, it's like things are controlled, there's adequate support, and teeth are easy to maintain by the patient. It has to be 1 or more of those. So that's good. Once you hit the fair, you have 25% of attachment loss. There may be a class 1 furcation, and location of furcation allows for proper maintenance of good patient care. That's a fair prognosis. A poor prognosis is going to be 50% of attachment loss with actual class 2 furcations, and the location of the furcation allows for proper maintenance. Once we get to questionable, though, you have greater than 50% attachment loss, poor crown to root ratio, class 2 furcations are not accessible, and you may have class 3s furcations, and then mobility 2+, and there's a root proximity, and hopeless is just extractions. So that's the old way, good, fair, poor, questionable, hopeless. The new way in this new paradigm suggests that periodontal disease depends on the microbial insult, the body's reaction to the insult, and control of the level of pathogens. Here we have favorable, questionable, unfavorable, hopeless. For favorable, the periodontal status of the tooth can be stabilized. Future loss periodontal tissue is unlikely if behaviors conditions are met. Then questionable is there may be local or systemic factors that may not be able to be controlled. Unfavorable is when periostatus of tooth is influenced by local or systemic factors cannot be controlled. And hopeless is just like the last one, extraction. Cool. So now let's get into gingival curettage. So what we need to understand is that subgingival curettage and open curettage is something we do not do. Okay, something we do not do. Subgingival curettage is an open curettage we do not do. What we do is gingival curettage. Okay, this is the removal of an inflamed soft tissue lateral to the pocket wall. Okay, so that would be the white arrow. We don't go any further down there. Okay, everything else is done by a dentist or a periodontist. So we do gingival curettage, but we do not do subgingival or open curettage. Okay, what is the rationale for curettage? It is the elimination of pocket epithelium to enhance new attachment, to make it better. Don't use the word promotion. Enhance means to make it better. It also is to the removal of chronically inflamed tissue and the enhancement of gingival shrinkage, even though shrinkage will happen without curettage. So do not use promote. Again, other forms of curettage can happen inadvertently, unintentionally. Hard tissue curettage is synonymous with root planing. So this hard tissue curettage is just basically root planing. And then chemical curettage is basically no longer used. We can also use the laser curettage, or it's also called circular debridement, which is like vaporizing of pocket epithelium, plaque, and some granulation tissue. It's usually painless. Hygienists need to take extra courses for that. Evidence-based data suggests SRP and curettage versus SRP alone. There's no significant difference. There's no therapeutic benefit. It only treats inflammatory effects. So wound healing is enhanced by a reduction of diseased tissue. Okay. Also, there's no code for curettage. So there is no difference between curettage and SRP alone. However, what are the indications for curettage? Here we go. Super bony pockets, which are above the crest bone, edematous tissue, new attachment, or maybe before surgery to reduce inflammation, or when surgery is contraindicated for patients who have like type 2 diabetes or something and they can't go under, or other serious diseases, or at recare, did all the areas resolve? Make sure to use anesthesia. So indications, super bony. Yeah, super bony means above the crest. Okay, if the pocket goes below the alveolar crest, then we can't. That's infrabony. Contraindications to gingival curettage are healthy tissues, fibrotic tissues, or hyperplastic tissues, frication involvements, or mucogingival problems. And usually it's done following a scaling and root planing under anesthesia. Okay, you would use a 7/8 Gracie or a 13/14 with long strokes using the sharp blade and a sterile gauze and a cotton swab. Insert the blade against the pocket, activate long horizontal stroke, light to moderate pressure, continuous, do not stop and start. It's a continuous one. And can be extended to intraproximal with an 11, 12, or 13, 14. Again, you can use your finger cotton swab with the opposite hand to apply light pressure against the tissue. Okay, and healing begins almost immediately. All right, likely to complete at 28 days. All right, and then we got the 1 to 2 days healing, 6 to 7 days healing, 10 to 14 days healing, 28 days is approximately 4 weeks. Usually the outcome is 1 to 3 millimeters of pocket resolution, expected with SRPs though. And that's that. All right. Next, let's talk about healing and repair. All right. This is one thing that we need to make sure. Again, here we're talking about healing in 1 to 2 days and then 3 to 4 days. One thing I remember we need to remember is the migration of marginal epithelial cells is about 0.5 to 1 millimeters per day. That was on the test. All right, that was on the test. 0.5 to 1 millimeters per day. Then we got 4 days of healing, and then we got 6 to 7 days of healing. Things are getting better. And keratinization continues and reaches normal bulk at 28 days. Okay. So mostly long epithelium attachment. Connective tissue attachment is rare. Some obstacles to healing are so plaque removal is needed for connective tissue attachment or junctional epithelial attachment. Soft tissue will not attach on altered cementum. All right. The older you go, cementum, let's see, altered cementum is exposed. As long as nothing is, it's the sulcus. Let's see, let's talk about factors that affect healing, which is obviously plaque, foreign substances such as calculus, and repetitive treatment during the healing time, not giving enough time to heal, and then smoking. Smoking is a vasoconstrictor. Also, overhangs in the cements are factors that can affect healing, which are local factors. Now, systemic factors are age, diabetes, poor nutrition, smoking, steroid therapy, hormones, vitamin C deficiency. Vitamin C slows the progression of disease and helps make collagen. Types of healing, we have 1, 2, 3. We have regeneration, which is the same tissue. We have repair, which is different tissue. And then we have attachment. This is very, very important. This was on the quiz, and I got one of these wrong. So types of healing: regeneration, repair, attachment. Regeneration, same tissue. Repair, different tissue. Attachment is reattachment, new attachment. Okay. Again, regeneration, same replacing same. So healing via the same type of tissue. Okay, ongoing process, and it's hindered by disease. Okay. Then we have repair, which is healing by scar. I don't think she wants us to put that, but it's healing by different tissue, gingival tissues, and junctional epithelium for the second repair type of healing. Okay, reestablish at the same level of pre-existing base of pocket. That's repair. Reestablish at the same level of pre-existing base of pocket. Okay, and it's all, and the clinical attachment is not achieved. Whatever happens first, so it's like, you know, epi, long junctional epithelium, CT connective tissue, B, bone ankyloses, PDL fibers, true, you know, cells to arrive first will win. And then there's attachment, new PDL fibers into cementum, okay? These occur in areas of previous disease, epithelial adaptation, pocket, and then reattachment refers to areas healing via the same fibers associated with trauma. So this is the thing right here where I fucked up. Reattachment was an evolved tooth. Okay, the root surface not affected by disease. So this is like reattachment. When it comes to reattachment, it's trauma that evolves tooth. All right, that's very important. Make sure we remember that. And then now we're going to be talking about preservation, periodontal therapy, patient management. So supportive periodontal therapy, SPT, is also perio maintenance. Okay, patients who do not return for regular recare visits are 5.6 times greater risk for tooth loss, have a 50-fold increase for probing attachment loss, and show obvious sign of recurrent problems. The rationale for periodontal maintenance is to prevent the reoccurrence of active periodontal disease, and we don't want to give a false sense of health. Bacteria associated with periodontitis can be transmitted between spouses and family members, even kissing them. Don't share a toothbrush, or eat an apple together. Patients may become reinfected, especially when patients with remaining pockets. The long junctional epithelium may be weaker than the new attachment. Lack of connective tissues. Okay, so new attachment equals PDL, not epithelium. New attachment equals new PDLs, not epithelium. Pre-treatment levels of bacteria are usually 9 to 11 weeks, approximately 3 months. There's a sound scientific basis for recall maintenance because subgingival scaling alters the pocket microflora for variable but relatively long periods. So periodontal maintenance is not the same as a prophylaxis, all right? Because continues at varying intervals for the life of the dentition or its implant replacements. All that includes an update on the medical history, radiographic review, dental examination, perio examination, removal of microbial flora, scaling and root planing, all that stuff. It is distinct from but integrated with active therapy. The patient may move from active therapy to periodontal maintenance and back into active care if disease occurs. The goal is to minimize reoccurrence and progression of perio disease. Sometimes recurrence of periodontal disease can happen due to inadequate or insufficient treatment, which is like a clinician error. We're not removing everything, or inaccurate restorations placed, or not replaced or removed, or placed after periodontal treatment, or patient noncompliance, or systemic diseases. Those are reasons why things reoccur. Recognition of a failing case is that we keep getting gingival changes and BOP whenever we probe. So if we see BOP after SRP, that means we didn't succeed in educating the patient or removing all etiological factors. So increased recognition of a failing case, also increased remaining sulcular depth, pocket formation, gradual increase in bone loss, gradual increase in tooth mobility. So we want people to be in Class A status, not Class C status. These are statuses that we of post-treatment patients. Class A is an excellent status, well maintained for 1 year or more, gingivitis on a reduced periodontium, usually 6 months. Class B is good results, generally maintained well for a year, but 3 to 4 months is 3 months is the standard due to bacterial levels reaching pre-treatment levels. All right, so this makes sense why people would be on 3 to 4 month basis initially before they go on 6 months, because we want to make sure that they're able to keep those levels well. And then Class C is poor, many factors. Those are 1 to 3 months. So again, before we put people in classes, you're going to do the treatment that's needed, which is the first year, the routine therapy, poor healing or difficult case, 1 to 3 months after initial 4 to 6 week evaluation. But again, Class A, excellent results. Class B, generally good. Class C, generally poor. We'll review that more. And then now we have antibiotics, antimicrobials, and chemotherapeutic agents. Systemic antibiotics, host response modification. There is locally delivered antiseptic and antibiotics, such as mouth rinses or irrigators. So Periostat is a host modification. Periostat is doxycycline. Dose too low to affect bacteria, good for uncontrolled diabetic. Host response modification, again, we're talking about Periostat, which is doxycycline. Medical problems that contraindicate periodontal surgical therapy are hypertension, cardiovascular disease, blood clotting, and diabetes. That might be indications of when to use something like Periostat. Clinical indications is generally advanced stage of periodontal where surgical therapy is no longer possible or carries risk if performed. Smokers who present with generalized diabetic presenting with generalized aggressive periodontal, the initial therapy, systemic antibiotics. So yeah, that might be good for people who are really sick, basically. And we can't do non-surgical treatments. Irrigation or microbial agents refers to a lavage or flushing of the pocket. It doesn't do much except for a lavage. But for an agent to have an additional effect after the non-surgical therapy, you must reach the site of disease activity. The base of the pocket must be used at bacterial concentrations and must be substantive. I have a feeling this is going to be on the test. Chlorhexidine is 0.12%, stannous chloride is 0.4%, provodone iodine is 0.05. Those are our irrigation antimicrobial agents. It needs to be continuous. However, microbial suppression is not increased when a one-time irrigation is used at the periodontal. One-time irrigation it's not doing more than the SRP alone. It's not going to sustain microbial suppression. Irrigation with microbial agents may or may not be in conjunction with scaling and root planing. Chlorhexidine gluconate is effective as an anti-plaque rinse to reduce gingivitis, but is not effective as subgingival irrigant to reduce periodontal pocketing. Iodine, we got to make sure people are sensitive to iodine, especially if they're pregnant, because iodine induced goiter and hypothyroidism in the fetus. Also lactating patients, transient hypothyroidism in breastfeeding. Microbial suppression is not increased when a one-time irrigation is periodontal. But one-time irrigation is not going to do more. Then we got the slow release, such as tetracycline fiber cord. Actisite is no longer available in the United States. Slow release Actisite is not available in the United States, which was a tetracycline placed in retraction cord packer in place for 10 days. Wow, 9-inch monofilament of ethylene vinyl acetate copolymer. Wow, that's interesting. Length of time required replacement 10 minutes per tooth, leaving curve for placement. Auxiliary cannot place. But this is no longer available in the United States. Tetracycline fiber cord. Wow. Packing cord for gingival disease. Interesting. Then there was Atridox. And then there was subgingival microspheres, which is Arrestin, at pockets of 5 millimeter or greater. All right, and we don't do none of that stuff. I know we don't believe in that stuff anymore. Watch video for exam. Okay, so we're gonna watch that video for exam. Make sure we do that. Again, these slow release antimicrobial agents are for pockets that are 5 millimeters or greater and may be applied after SRP using specific rationale such as uncontrolled diabetes or if there's localized areas. Perfect. So that was that. All right, Daniel, ready to kick some butt. Whoever else is listening to this, we're going to kick some butt on tomorrow's test. Very good. Thank you very much. Boom. And